This is held in collaboration with the WHO collaborated center in Imperial College London. Let me start with introducing myself. I'm Associate Professor Dr. Lujain Al-Hazraji, Consultant Family Physician, Faculty Member of University of Baghdad. We all know that COVID-19 is an alarming health crisis, global health crisis, which demands changes in behavior, a lot of behaviors for people, where people encouraged to adopt, let's say, preventive and behavioral changes, which may lay a burden, a significant psychological burden on these individuals, their families, their communities. Therefore, insight about the social and behavioral science will help to align these changes, these behavioral changes, to meet the recommendations of the public health and epidemiologists regarding the COVID-19 pandemic. So the topic of the 17th webinar of the Arab Public Health Association is about COVID-19 and behavioral change. We have the distinguished speakers that will share their knowledge regarding this topic. We'll start with Dr. Saad Fayaz Ahmed Khan, who will start as the first speaker. Dr. Fayaz is,
Senior technical.
Senior, yes, sir. Dr. Fayaz is a senior technical from Johns Hopkins, who will start to be as the first speaker for this webinar. Senior Technical Advisor, Johns Hopkins Center for Communications Program. Would you kindly start, Dr. Fayaz? Thank you.
Thank you very much. Thank you very much, and ladies and gentlemen, for joining us today. I am extremely happy to be part of this distinguished panel. As I was introduced, my name is Fayaz and I work for Johns Hopkins University. And my today's presentation is based on a rapid literature review that we have conducted recently on COVID-19 and behavior change response. And we plan to convert this into a policy paper for WHO AMRO region very soon. So to start with, I would like to share with you that
there is no voice.
Hello?
Yes. As you muted, yeah.
Now it's okay. Now it's okay.
So let me start again. Greetings, everyone. I'm really happy to be part of this distinguished panel. My presentation today is based on a rapid literature review that we have conducted on COVID-19 and behavior response. And we hope to convert this into a policy paper for WHO's AMRO region on the same topic. There is no denying the fact that COVID-19 has shocked the world in every aspect. And to control its community transmission, the key response has consisted of what Stephen Vaughan has called as non-pharmaceutical interventions. Because we have been promoting various forms of behaviors, such as hand washing, wearing masks, keeping distance from each other, and observing respiratory hygiene. However, despite that, in the recent past, we have all repeatedly heard, even head of states of some of the very wealthy countries, saying that we have acute shortage of ventilators. Hospitals don't have enough beds. There is no vaccine. We are short on medical supplies. There is not enough budget, and we did not invest in our hospitals. We have all heard these things. The question is, did we also hear we need trained health promoters? We have not invested enough in health promotion. We need better tools for reaching out to people, and we need a more effective communication strategy. We probably did not. And it is probably because the COVID-19 fight has focused more on transfer of knowledge to individuals rather than creating opportunities and conditions for them to use that knowledge. Similar to what was done during the early days of HIV epidemic, and those of us who have worked there would remember that, it seems the public health authorities have not recognized that using new health-related knowledge is an active cognitive process. To inform themselves about any disease and ways to protect themselves, people actively select knowledge. The key is this selection is influenced by context, inclination, emotions, selective attentions, and so many things. When I was thinking of these biases, I just put this cover of the classical Shakespearean tragedy, Macbeth, where the warrior, Macbeth, believes he is protected by the prophecies. And despite the fact that he knows what he's doing is wrong, he is forced to do that because of that. Now, there are so many of these information processing biases. Negative information bias is the doomsday scenario, and we all know that. There are people who believe in negative things. They always think about negative, and that results in catastrophic thinking. The positive information bias is the opposite to the negative information bias, and is the tendency to consider oneself as less at risk of negative consequences. The third is the recency or the familiarity bias, which is that our memory retrieves only that information which is recent and more easily available, and hence we can always refer back to it. It's not mentioned here, but there are other biases as well. For example, there is one which is called ostriching, where people actually just close themselves to the negative information and don't want to think about that at all. So all those biases actually process the information that we get. Now, talking about these biases, I looked at some of the recent data, and an online survey was of interest to me. This was coming from India, conducted by Ravindra Mehta et al. They brought forth some interesting insights. They conducted a survey, an online survey in India. All respondents were extremely well-educated, college and university level. All of them were middle class or upper middle class, so affluent families. And most of them were living in urban areas. And hence, all of them had very high level of awareness. But what was interesting, that 32% of them were not following preventive measures against COVID-19. 15% did not have any fear of infection. And if we think about India being a developing country, let's go to a survey conducted in US and UK in May and June. There was again high level of knowledge, but misconceptions about prevention were there, and belief in falsehood that has circulated on social media, and we see it so much. There was really that as well. Am I okay? Is my pace okay?
Yes.
Perfectly okay. You can hear me well, right?
Yeah.
Thank you very much. Now, besides these cognitive biases that I have just mentioned, there are structural hindrances to certain behaviors as well. According to a report of the Imperial College London, low-income communities are less likely to follow any knowledge transferred to them on COVID prevention and healthcare. Not because the information is not reaching them, but because of structural issues which limit their capacity to act. Hence, the use of COVID-19 knowledge is not only determined by the variation in threat, if I refer to the classical expanded parallel process model, but also efficacy to act. If the communities don't have water or soap, or they live in congested localities, recommended practices will not be adopted. Then our emphasis on individual responsibility, focus on health education, where the focus of attention is always the individual. In protection and care about COVID-19 has burdened the individuals with control and protection of the infection. This has contributed to stigmatizing those who are infected. And hence in many societies, and I'm sure Arab societies may not be different, we see people with infections doing everything to hide the infection. And that is because of that stigma that has been created because of the individual responsibility. Now, UNICEF has also brought in a very interesting but a very concerning information as well. They have pointed out that in some communities, social distancing was associated with controlling the mobility of women, making sure they would not get out of homes, not see other men, and hence become, what they call the term as, the gender norm of seclusion that, UNICEF has coined. Hence, this interpretation of social distancing has become a potential threat of domestic and sexual violence as well. And this is an interesting, aspect of this debate. This could be controversial as well, but this has definitely been seen in a number of societies where this seclusion has actually, focused the attention on some of those gender norms that are there in the societies. COVID-19 epidemic has been overwhelming. The initial measures of fighting against it were the same as we have seen in the past: remote, primary, one-way, one-to-many communication, comprising of press conferences, radio and TV broadcasts, mass media, SMS. All this is not useless. It is important, no doubt about it, when we are dealing with a pandemic, because people have to rapidly get this information. But then in some regions, this was slowly replaced by strategies of community engagement and community-led responses. Now, the experts think, and I'm sure you guys are part of that if there is a second wave of COVID-19, it may be in less densely populated areas where the reach of broadcast and digital channels may be limited. Hence, community engagement might be the key strategy to save the COVID-19 transmission at larger scales. And this is my favorite slide, I must say, when I was making this presentation. As I've been mentioning, that COVID-19 has changed the way we looked at the world and the way we conducted business. It has also brought with it an information overload. And you go on internet, you switch on TV, we all are exposed to that information overload. But this overload of information also exposed the inadequacies of the system to deal with the pandemic. We realized that despite having resources, we did not have the competence or the capacity and the right tools to come up with effective social and behavioral change materials. The pandemic has also exposed a lack of cross-sectoral coordination to use new knowledge to design effective products. And more importantly, there was an inadequate use of local data for more local responses. So, I have tried to hide the sources, but billboards are extremely expensive. They cost, thousands of dollars. And you can see there is a gentleman who has probably erected this billboard with his own money, asking people to wear masks, but he himself is wearing the mask, wrongly. Now, based on what we have done, what the research has told us, based on that, I have put forward some recommendations, for this panel to consider, and this will be part of the paper that we are going to submit to Emro region as well. I think the first lesson that we have learned is that we need to invest in health promotion. There is no way out. We cannot improve emergency communication without improving communication, without improving behavioral sciences, without improving health promotion. It will not improve in isolation. We cannot have one wing which is extremely good and overall we don't have the resources for it. So this discipline itself needs investment and a lot of investment. Then we need to combine health promotion with other administrative and legal measures so that people can, just like, we have learned, people have been wearing seat belts because, it is a behavior that has been promoted, but then there are legal measures as well. And some of them we have been seeing in shopping malls. You are supposed to put a hand washer and, soap outside. People are not supposed to enter without a mask and so on and so forth. So it has to be a combined combined behavior that comes with the administrative measures as well. Then we also need to use combination prevention. It is not one action that will lead to a decrease in the COVID-19 infections. Social distancing, hand washing, use of face masks, avoiding of mass gatherings, maintenance of respiratory hygiene, along with community seeking, health seeking behaviors and other things. That is where the success lies. We also need to simplify and contextualize knowledge transfer. Believe you me, for a very long time, I was really surprised what we mean by social distancing when we give this message to a woman on a bus stop in a rural area of Zambia or Malawi. So it is really important for the communication gurus to come up and simplify messages and break it into small doable actions rather than creating something that will look very awkward for people or will be unimaginable for them. For example, you go to market maybe once or twice rather than saying stay at home. This message for low income communities, for daily wagers will be almost impossible. Similarly, promoting harm reduction roadmaps to low-income communities to reduce risks rather than eradicate risk. It should not be, all or nothing. It will not work like that. The key thing, that I'm sure everybody says, but probably we don't practice that much, is pre-testing of messages. A number of good messages would mean totally different when they are taken to the community. And this can also, help when we go for the local data. The other thing is, this may be new for some people, the message matrix. This is just, which is an amazing tool, very, very simple, 4 forms. It is available on the website. I've given a link to it. I find it extremely useful, when we are designing messages for specific communities or specific groups. We can sit with them and quickly design messages that can be extremely effective, and a link is there. Finally, I think, I have seen some of the very senior people, some head of states, talking to people and saying there is no fear, we have to fight this thing. It is good for a political debate and for political point scoring, but scholars and those who understand the science will tell us that acknowledging fear is extremely important. Fear is easier to handle when it is acknowledged. Rather than saying there is nothing, we have to talk about the fear, but also raise the efficacy that yes, it is an epidemic. Yes, it is a dangerous thing. We can contract it. But if we take these simple things, hand washing, keeping away from crowds, so on and so forth, we can easily save ourselves and others. Then the key thing, which the point that I talked about, was individual emphasis. I think we need to come up and talk about the community engagement and boost this as much as we can. We need to promote community-led actions. Surviving the crisis should be a collective responsibility. Hence, collective approaches would be needed. With this, we need to tap into the social identity of group members to reinforce solidarity, cohesion, action, and then reframe COVID-19 as a social problem with shared consequences and solutions. If we do that, we will take away the stigma that has driven a lot of people away from care seeking, and will also come up with solutions that are more owned by the community. So it should become a collective response rather than an individual response. And the final item from me would be looking at a whole of system approach. We have seen a lot of resources being devoted for COVID-19, but we have seen not enough systematic, across the board cooperation and support between government, communities, institutions. And they need to work together to share knowledge, avoid duplication, and leverage unique resources. If we do that, our response will be more comprehensive and probably will be able to match the challenge that this unprecedented epidemic has posed to the humankind. I think in the end, I have listed a resource which I find extremely useful on here. It is the Health Compass, and it has a lot of useful resources for behavior change, health promotion, and health communication. With this, I thank you very much, and I will hand it over back to the host. Thank you very much.
Thank you very much, Dr. Fayaz. Now we'll call the second speaker, Dr. Marcos Bardos, Assistant Professor, American University of Beirut, Lebanon. Let me share his knowledge about this topic. Dr. Marco.
So, hello, good evening, good afternoon, or good morning, depending on where you're based. So I thank you for having me today. And while Dr. Fayaz was speaking, I took some notes in addition to the insightful discussion that we can have later on. I propose the following points. I'm a communication scholar, so what I am interested in is understanding how we can communicate better instructions for COVID-19 prevention. So I think what we needed, or what we need still, is from a strategic viewpoint, for a strategic communication viewpoint, we need better plans, and we need to apply existing plans for social and behavior change communication or for risk communication and community engagement. I'm not sure that all countries are knowledgeable about these frameworks or these approaches. So this is not problem number one, that maybe there's not been a good effort in trying to promote this kind of planning. So in a sense, preparedness for tackling this pandemic. Or on the second level, probably there are plans, like there have been developed plans for since other pandemics before SARS, other influenzas. In the United States, the CDC has developed a CERC framework for crisis and risk communication, risk and emergency communication. However, these plans have not been applied. So I think this is one important problem that we communicators, public health professionals need to acknowledge and need to face, on top of the problems that Dr. Fayaz mentioned in the lack of intersectoral collaborations. So when we have plans, we should apply them. Then I think another point we should consider here is analyzing the communication flow. So we have a problem we have several problems related to the message. We have several problems related to the messenger, and we have the problems related to the channel. Let me have this, categorization. Let's go for the problems related to the message. We are dealing with a novel coronavirus. So the scientific community has to still understand how this virus works, even though we are quite, many months now in the pandemic. So we know a lot, but we don't know everything about this pandemic yet. So there's a problem of communicating uncertainty, and from a scientific viewpoint, and also from a layperson viewpoint. This results in multiple types of messages, and people might find it confusing. So yes, we should wear masks. Yes, we should keep a distance. But think about what is happening now in some countries where public health officials are saying you can meet up to 6 people. I'm thinking about the UK now specifically. So the rule of 6. Yeah, it's very memorable, but then you say, why 6, not 7? So in some parts of the UK, the rule includes children, it doesn't include children. And one, researcher, like a health communication specialist, will ask, why this confusion? There might be reasons. So these decisions that the government has taken are evidence-based. However, they are probably not well communicated and not well explained to the people well enough for them to understand and to accept these changes. In other sense, there you can persuade someone, but you cannot necessarily convince them. So I put it from this point of view as a major flaw in the communication that some countries have adopted so far. And this is a problem of the message. In some countries, there's been a politicization of the message. So some countries have taken the disease as a sort of way to push their specific political agenda. And I'm not talking about the Western world, I'm talking also about other countries in the global South. And this has to deal with the fact that the sources of information, then I link it to the messenger, are not necessarily experts in the field. And this is like, risk communication 101, whereby the spokesperson should be an expert in the field. Now, many countries in the world, when they have a press briefing about COVID-19, the spokesperson is a political figure. And this is a problem because that political figure, whether you like it or not, they are not experts, they're not epidemiologists, they are not virologists, they have no idea what the virus is. So they hear from their experts what they should say. But doesn't mean necessarily they understand what they're saying, nor they understand the consequences of what they say. And this is, I link it again to the content of the message to the problem of risk communication, so the perception of the risk. It has to deal with the perception that everyone has, so the biases that Dr. Fayaz mentioned before. And one of the elements, Dr. Fayaz mentioned the extended parallel process model. For those who are not familiar with this model, it's about information processing. And it's about the way we understand, we process risk information in relation to the perception that we have about the threat. It relates, of course, to fear. If we are very scared, we might ignore a message because we are scared. We ignore something that we don't want to hear. That's a level one. So if the message does not include a self-efficacy component and saying, yes, it's good to be fearful. However, if you do the simple thing, you will be less likely to get the virus. So this is, I wanted to stress again what the Dr. Fayaz mentioned. So self-efficacy messages, action-oriented self-efficacy messages are at the moment not well developed globally. Then we talk about, so the message, I concluded the part related to the message, the content. When we talk about the messenger, so who is speaking, who is talking about the COVID-19. Here we have a main problem related to the inconsistency of the message. And sometimes, and Dr. Fayaz mentioned, so there's a billboard with the person saying, let's fight COVID-19 together, and they are not wearing a mask. Or we have some political figures in the world that promote mask wearing without wearing the masks themselves. And this creates inconsistency. And people will not believe in that. And then another major problem that we have in some countries of the world, in particular, I think in some countries of the Middle East, is the lack of trust towards government or ministries that have some political affiliations. And I think this creates another layer of complications when you're talking about what are the measures that we should follow for COVID-19. So I'm based in Lebanon, and I'm also working, collaborating with the Minister of Public Health on a contact tracing application project. And one of the issues that we're facing now is how to convince the population to download and use this application that will help the contact tracing efforts that the ministry is currently doing. And when it comes to the problem of communicating, the source of the message is important. So if it comes from the WHO, if it comes from an international NGO, UNICEF, UNHCR, the message has a different perspective. But even here, now, with the situation that we're living in, financially, economically, financially, socially, the country is suffering. So all this, the messages that are oriented to health might not be well perceived because there are other priorities. And if the message comes from the ministry, you are sure that most of the people now will not believe, will not pay attention, will not listen to that. Now, how can we cope with that? How can we communicators instill trust? There's no way you can instill trust. You have to demonstrate. Like in any relationship, an interpersonal communication, you know that. In order to establish trust, you need to be consistent. You need to show that you can deserve a person's trust. And in this sense, I think the best way to do so is to show transparency. So, and here public health professionals can help the governments be upfront and say, be clear, this is the situation we are facing. This is what we need to do. Yes, it's important, we need to be careful, we need to follow specific procedures until we can control the pandemic. So for me, these are the two main elements for the messenger, in relation to the source of the information. Then we have the problems related to the channel. And here, so the Dr. Fayaz mentioned the fact that some research, some surveys were done with the highly educated people with high education and online. So this is the problem of nowadays. We are remotely connected and we need to communicate this way. And we have our classes now are delivered online in most of the cases. We make the assumption that people know how to use the technology. And this is a big assumption that communicators should not make all the time. It has two different problems here. First is because there's the assumption that everyone knows how to use the technology. So there's information on technological literacy that we are assuming that people have. Second, we assume that everything we deliver through the technologies is completely understood. Then there's another assumption we make is related to the level of health literacy. It's a concept that we need to talk about in health communication. And we need to adapt our communications so that everyone could understand. So I'm not sure that and here this is a mea culpa that I do as a health communication professional, I'm not sure that we had spent enough time to pre-test the messages that Dr. Fayaz mentioned, and to make sure that everything we say is clear for everyone, or not for everyone, but let's say for most of the people. Another aspect related to the channel is that we are trying to promote some behaviors using digital technology, social media, and so on. Yet on social media, a lot of information or overflow of information is tainted by conspiracy theories. So we are facing the so-called infodemic. So we are fighting fire with fire. And this is another problem because, again, we need to teach people how to interpret different messages, how to interpret different sources of information, how to judge and how to validate the information, which is something that is not easy. And not even our children would know how to distinguish a specific message if it comes maybe from a family member via WhatsApp. And this is something that global affects, let's say, the global society. Some companies like Facebook, Google have started doing something in collaboration with WHO, trying to minimize the risk, let's say, of exposure to conspiracy theories, but it's a battle. The war is still far from being won. And we need to be very well aware of this when we develop our messages. I wanted now to talk about another aspect related to the perception of fear. So in relation to the extended parallel process model, it's related to also the level of threat. So we might need, as public health professionals, to tweak and rephrase or rebrand COVID-19. Why do I use the term rebranding? Because we need to make sure that people understand the risk, yes. At the same time, they need to understand the benefits from following specific behavioral procedures. So why should I wear a mask? Is it for me or is it for the others? Why should I keep physical distancing? And the other day I was watching a YouTube video, and I don't recall exactly where from, but they were talking about climate change. And the message related to climate change has been probably misunderstood or framed in a wrong way, according to this person. and saying, so far we talk about climate change, we should do something to save the planet. This might appeal to a very small percentage of the population who are interested in preserving the planet. So they are environmentally friendly, they are pro-environment. But why are we talking about saving the planet? Why the planet will still survive? The planet has survived pandemics, has survived massive distractions. The dinosaurs have disappeared in the past, and the planet is still here. So I think we should talk about, and this is what the claim was, we need to talk about saving the human race. So we need to reduce CO2 emissions because we need to save the human race. So for COVID-19, it's not probably, we need to change, to rephrase the way we talk about COVID-19. It's not only, yes, we have to flatten the curve. We need to break the chain of transmission. We need to save the human race. Because eventually, if things go bad, there might be not many people around. So this is about the rebranding of that. Last point I want to make is about these developing equitable community-based solutions. Equitable, why? Because the messages that we're talking about now are mostly appealing for Western societies, affluent societies where people can afford to stay home, for example. They can afford or have the resources to work remotely. They have good internet connection. They have not been laid off, or their salary is based, let's say, on services they can provide, even staying from home. But there are a lot of communities that cannot afford that. A lot of communities, a lot of people are forced to preserve their livelihoods, to work and to do their daily jobs. And these people might not be necessarily exposed to the same type of knowledge and information that we are. And so I think we need to be very much oriented to acknowledge the limitations of what we have done so far, and to be more inclusive, more equitable, more morally appealing to everyone. And I think I can close here. I have other comments, but I'll leave it for later.
Thank you very much, Dr. Marcus, for your presentation. Now let me invite Professor Salman Rawaf, President of the Arab Public Health Association, for the panel discussion. Dr. Salman.
Dr. Lujain, thank you very much indeed for chairing our session, and my thanks to Fayaz and Marco. I really enjoyed the two presentations. It gives so much insight, but also it put us on the rail of not only challenging ourselves in communicating the right message, but also in changing the behaviors. The message may be right, but the behavior is not changing. And last night I was on TV and actually I asked this specific question, whether people awareness is sufficient enough. I said, you may be aware of the danger, but you don't practice risk management. You know it's risky not to cross except in the places like the zebra, but yet you don't do it, So that doesn't mean your knowledge is complete, or you absorb the message, or you understood the message, unless you practice it, And this is applied to everything we do in life. Let me say something which is recently communicated by my friend Richard Horton, the editor of The Lancet. And he was actually referring to some book about epidemic and pandemic and its impact on society. I mean, I, and many other people believe following big epidemic and pandemic, society will change. They like it or not. We will be totally different people. And I think say, COVID pandemic, in maybe 5-6 years, we will be totally different people, everywhere around the world, because we were very much affected. There is not a single person on the globe is not affected by this event, whether from the health-wise, social-wise, or indeed economic-wise. The second point, government will change. I mean, the government attitude also will change, and will change radically. I mean, the best example is a lot of governments around the world now realize how important to strengthen the public sector, how stupid it was to minimize the role of the public sector in health services. And that almost listened to all of us on the health system development, but also for government as well. Also government and the interaction of government with the population. I think, Marco, you said beautifully or illustrated beautifully that politicians always appear at the front line, but they know nothing about the virus or indeed the disease which we are talking about. I'm not sure they know nothing. I'm sure they are intelligent enough to be a prime minister or president or something like that, with a few exceptions, not to be mentioned tonight. But certainly they do absorb the information. And I know how politicians have a beautiful capacity in absorbing technical information, including highly sophisticated medical information, very quickly. And they communicated that in a way, and you are the master of communication, Marco. They communicated in a way which is to the level of the population which they know and they understand. You are absolutely right. Sometimes they do create confusion, and you cited the example of the rule of 6 in the United Kingdom. But I think we shouldn't shoot the messenger, because our behaviors, and I want to zoom on behavior here, our behaviors is shaped by so many things. I mean, my behavior most probably is as a result of how I raised in my family. So that the influence of the home, the house, when from the age of 2 or 3, when I start to recognize things and touching things and handling various simple tasks, then it is shaped by my school, shaped when I grow up a little bit more, shaped by the various religious codes, especially in the Arab world. Religious codes tend to be very much dominant in some cultures, in some societies. Then shaped by some of the work environment. And last but not least, and we've seen it in the drug misuse and the smoking and certain behaviors, is very much shaped by the peers, the people I mix with. And that is, if you take all that in collective way, changing behavior is not easy at all. I mean, in my opinion, it's very difficult. We did some research in one of my book, and Anne MacDonald from Royal Free Hospital, she is a fantastic writer. She written a chapter about behavior change among clinicians. And she noticed that even with the strongest evidence available for clinicians, for example, prescribing or a new drug or a new technique, they tend not to absorb it on average by 8 years. It took, with the new evidence, on average about 8 years for clinicians to change their behavior. So when you have a layer of the society, highly educated, highly aware, like doctors, are not changing their behavior, it took some time, from 0 changes, and from something could be changed immediately. But on average, it takes about 8 years, So I think I want to come back to you and saying, we need different techniques, and I think both of you, Fayaz and Marco, you alluded to it in terms of current techniques of changing behavior, i.e. health promotion message, the nucleus of fear, and just departing information may not be successful at all in the situation where we are, you know. So I want to listen to you and Dr. Lujain in terms of what are there any new ideas or technique to influence the change in behavior among population who have fear but don't follow governmental instruction? They know the risk, but they don't care about it, as some of you mentioned already. To you, Marco? Yeah, Lujain, carry on.
Yeah, if you allow me, thank you very much. Actually, I'll give you what I've noticed, my experience in Iraq. Dr. Fayaz even said that it's the low-income setting communities that challenge or resist change in behavior. Actually, in Iraq, it is not true. Yeah, it's not the same. All level of community, high-level community, low-level community, educated people. You know, in Baghdad, we are living now a crisis. Perhaps I'm the only one who wear personal protective measures in Baghdad. It's even in let's say a high-level community, let's say among educated people. I mean, I tell you my personal, I'm a teaching staff, a teaching faculty in a college of medicine, yet I notice and I may see many faculty members, they don't wear the mask or they don't even have the sterilization, you know. This is an issue I want to discuss it. I mean, our government is following the protocols. They even started legislation for that, you know. No matter what health promotion, health education, I mean, the health personnel, they are, let's say, traveling or moving among in markets and among let's say schools, they are emitting messages, yet there is resistance. Really, some of them till now they don't believe there is a pandemic, you know. Yani when you ask some people on the street, what's your measures, what the measures you are taking in your home, in your work about COVID-19, he said there is no COVID-19, it's only a political issue to destroy our country. Just like that, you know, this is the concrete thinking here. We don't know how to face it. I mean, the Ministry of Health, let's say, the educated people are trying their best, okay? But we face with this this response of our community. I don't know. I think it's not related to the socioeconomic status. It's not related to the educational status of the person. It's rather about the health education, which is an issue that should be raised in the community itself. I mean, through the rear-up of the family, of the community, of the children, of the, I mean, it's not having a higher degree or having a high economic status doesn't make difference, you know. And we're here in Iraq, we're having higher numbers, confirmed cases and higher deaths. Every day we do have, you know, the screening test for a certain number. Yet those who doesn't have the screening test, we don't know about them. I really don't know what is the new approach for that. The WHO also every time emit messages that Iraq will face worst results of pandemics. The coming next 2 months will be a problem. But yet you find the people in the markets, in their places, in their homes, they don't follow the minimal protective measures for themselves and for others. So this is a very massive problem in Iraq.
Yeah, Marcos? Thank you, Lujain. This is fascinating. Sorry, Marcos.
Yeah, so these are what you mentioned, so that behavior change takes time. So I think this is one of the first elements to consider. So what we have been hearing, I don't know if that appeals us to you as well, we need to enforce the new norm. So we need to change the way we live. And as you said before, this pandemic has affected already the way we live, the way we travel, the way we do business. So it's true that it has impacted, but people might not realize this because it takes a lot of time. So when the global, when the pandemic affected most of us with the lockdowns, that's when people start realizing, oh, we cannot go back to the way we were before. But we cannot lock ourselves down all the time, every time that there's a, so this is one option, and lockdowns have been designed to curb an outbreak for a shorter time, so 2 weeks maximum. Then we stayed in lockdown for months, and that had mental health implications. Okay, so that probably is not the solution. So when we talk about communication here, it's about repeating information, and ancient Romans used to say repetita juvent, and communication scholars know that. So when you repeat something long enough, people would remember. So we need to probably think about that. We need to be consistent with the same messages and repeat it until it becomes default. That's one element, I think. And then probably need to follow social norms approach here. We need to change the norms. We need to change the fact that whenever we go out, we need to wear a mask, and we need to keep a distance. Not only for the time that the pandemic is going to stay with us, but for long enough. But another thing you mentioned, so behavior change takes time, it takes effort. And social marketing, for example, I teach social marketing here at the Faculty of Health Sciences. We know that one of the first things in developing social marketing plan is trying to understand the target audience beliefs about the barriers of the behavior. So I think I would start by developing plans and communication activities as the last step before we need to understand better why the populations are behaving a specific way. So getting the insights from the population, this is a key aspect for me. So I would say in Baghdad, why are people not wearing the mask? Why are they doing it? They're doing it in spite of the government, or are there other reasons for that? So I think we need to look in more detail and in depth in order to understand the behavioral limitations, the barriers to behavior, and what would motivate people to follow these approaches.
Marco,
For me,
before I go to Fayaz, I mean, you raise a very important issue, but link it to what said about Baghdad by Lujain, is that there is obviously resistance.
yes,
Irrespective of the background, people resisting.
as denial,
Yeah. Is
Yeah.
it because of political disagreement, or I don't like the government, I don't going to listen to them? Or is it because denial? I mean, I know the chair of the Health and Environment Committee at the Iraqi parliament, and he's a public health person, appear on television and say there is no such a virus, go and feel free, etc. I mean, that is the extreme, But the other things, is it something else, that the message wasn't the right message and people did not understand it? Which one of these? Or maybe other things?
I think it's a combination of factors, not only one thing. So we cannot blame, like you said before, you cannot shoot the messenger, It's a combination of factors, and people might be just tired to follow these instructions. They desire to go back to normal, but it's not possible. So this realization is probably has not occurred until they face the problem, until probably they get infected, and then they realize, oh, this is not a joke. But I don't wish anyone to get the virus. That's not my point. So it's not that we need to infect everyone to let them understand. The point is, for me, is that we need to find different strategies. We need to find different combinations of messages. And in order to do so, we need to understand the target audience beliefs and barriers for that.
Yes?
If you excuse me,
Sorry,
it's about two things. I think different messages that are giving to the population, not the governmental one. I mean, the social media nowadays, I think as if it's a curse, you know. You may find, you may have your Facebook and different messages there for example, type of food, type of medication to overcome this problem. And the second thing is too long isolation, as Dr. Marcus said. You know, labor workers, you know, they work day by day. So if you keep them in isolated or prevent them from work for, let's say, 3 weeks or 1 month, this is a problem for them. This is one of the main issue. As for the messages, even as let's say the religious committee of say Al-Marja'iyya in Baghdad and in Iraq, they reinforce the use of personal protective measures. So we see the Iraqi government goes in every direction. I mean, through the messages of Ministry of Health, through health promotion, through health education, through primary health care centers or any health institutes in the country, and even from the religious side. Yet there is this, there is no response. I don't know why, really, I don't know why. I think, to my knowledge,
nobody listened.
Yeah, nobody listened. To my religion, and we should go with the penalty, you know. This is the only way. I hate it, but you know, in Kurdistan, those who doesn't wear mask, they are charged for, you know, a penalty for those who are in cars or they are working. And this way they can control. Although there is, there is an increasing number of confirmed cases, even though. But you have to have legislation and keep this legislation and to be applied well. Otherwise, everything we tried everything.
A lot of people, they don't know that actually the decisions of the higher committee for the control of pandemic in every country, their decision is a law.
Yes.
Without going back to the parliament. They could inform parliament. But if you have, for example, what we call our committee in Britain called COBRA, which is headed by the Prime Minister, the committee in Iraq, Health and Safety Committee, is headed by Prime Minister. So when they make a decision, because it's headed by the Prime Minister, that decision is a law.
It's executive decision, yeah.
It's executive decision, exactly like President Trump signing. He doesn't need to go to the Congress for approval.
Special governmental
later, you know. I think I did challenge a few members of parliament in Iraq and other Arab countries in saying that these committees don't need to go back to parliament. This is under international health regulation and it's very clear. Sorry, Fawaz, we delayed you to respond to the comments. Carry on. Fayaz.
Thank you very much. I think all of you have responded to these questions, and there is no one answer to these important questions.
But we need
the key thing is, you know,
we need a crispy answer.
I will try to.
The public, Fayaz, need a crispy answer because the public are not comfortable with contradictions and changes so fast. These are wrong messages.
If there are inherent confusions within the system, there cannot be one straight answer. You know, in Chinese is a very interesting language. In Chinese language, there are no alphabets, I'm sure you know, but just I'm trying to make a point. In Chinese language, the word crisis is written by two words. First is danger, the other is opportunity. COVID-19 has exposed us to a crisis where definitely there is a danger, but there is a great opportunity also to look at the systemic inadequacies and come up with responses. Now, this issue of Iraq, you know, I've never been to Iraq, But I know about a number of countries where these issues are, where people, educated people, just deny it. And by the way, I mentioned, I gave the example of America, United States of America. It's not only the low-income communities which are not under. I talked about low-income communities' structural barriers as well, which may stop them from taking an action. But even in the US, highly educated people are saying, where is Corona? I think we should look at how messaging is being, and I think Marco raised a very important point. I will give you examples of two head of states. I'm not going to name them. We are at a WHO forum, so I have to be careful. One of these, one very, very strong country. Look at the behavior of the president and the way he did messaging around COVID-19. He denied it. He said, it is not there. It is just a flu. Nothing will happen. For a very long time, that very important person, refused to wear a face mask, despite the fact that the country went through such huge crisis. Yeah. Another example from a developing country that I belong to. The prime minister appeared on TV and said, COVID is just like a flu. 95% people will suffer from it and nothing will happen. Then you imagine somebody going face mask, not shaking hand, why? The president of the country, the prime minister of the country is saying it is just a flu. So do I go and, keep distancing from, I don't go partying, I don't, just because there is a flu? So I think there has to be some blaming as far as the topmost personalities are concerned, where messaging has been done. And of course, there is fatigue as well. It's such a long thing, we have to come up with, issues and properly understand why people are not following behaviors. But I will be the last person, though a number of people, including some prime ministers, have blamed people for not following the action. I think we need to blame the experts for not being able to come up with messages that were convincing and that resonated with the reality of the people that they were living.
And Pakistan, they have the country which you referred to. Today, the figure for Pakistan mortality is 6,393, which is the third country after Iran and Iraq. Iraq is number 2, and Iran is number 1. So it's not a small number of deaths. I mean, luckily in our region, the cases are not high. I'll come and actually challenge you, the three of you, on these issues. But before I go to the questions, we got a lot of questions and comments from colleagues, I must say, very high number. All of you talked about community engagement. And I want you to think about, because I'm going to make a statement, may surprise you. It doesn't mean anything. And I really changed this term, in recent publication in relation to COVID. I used the term in terms of community acceptance, because all this engagement is simply one way. You think you are engaging them. I never seen in any Arab countries lay people on the management team of X and Y hospital, or on the management team of the Ministry of Health. So all of it just say, and I wish WHO, and I said that many times to our dearest brother, His Excellency Dr. Ahmed Mundari, we have to change this terminology because they are absolutely meaningless. We need to be more robust. I think we have a nice question from Celine. Celine saying, she's Celine from Beirut. Do you believe that health professionals need to be trained to communicate? And a few people agree with them, to communicate better. Because, I mean, there is strong belief that health professionals are not necessarily good communicators.
Yeah. So, Ahla wa Sahla, you can come to AUB and get trained in health communication.
So how do you train me? How do you train Lujain? We are health professionals.
Yeah, I have a course on communication skills.
I also
Dr. Saab did give me.
Ahla wa Sahla. So we can go to Beirut and to Baghdad So no, it's important. So now, jokes aside, I think it's very important that so at least the people that need to talk, I mean, they need to deliver a message, they need to be trained on how to communicate. So a spokesperson, not necessarily the political person in the room, needs to be trained in that. They need to be ready to communicate. So we need better communication, but it's not the only issue here. This is probably the surface that we are topping in this case.
We have a question, Fayaz, from, and maybe medical, from Amal Khalil, or Amal Khalil. I think I read it Amal. She's talking about really because of the lockdown and because of the fear, etc. The prevalence of mental disorder are on the increase. So what do you think? How that could be avoided or could be addressed?
I think this is 100% true. These disorders are on the rise. Not only that, if you look at the literature, and you are a scholar, you know that there are estimates that we are going to see not only rise in mental order, but in a lot of other diseases as well, because of this lockdown and because of this. Hence, we have to, as you said, we have to prepare for a new world order. And in that world order, the reality of the commoners, those who cannot sit in their office and have online classes and get their full pay back. We have to come up with interventions that can help people get out, do with their work, and come back. Mental illnesses and their remedies and their care is extremely rare in the developing world. In fact, these mental hospitals actually become a cause of more mental illnesses. You know, I was a reporter in the beginning of my career, and I've seen some of these mental hospitals, horrible. And this, in fact, this COVID-19 pandemic has definitely, and it is not because of isolation alone. As I mentioned, it is because of so many other issues like domestic violence. You don't have, job. You are worried about your education. You are, and even parents are not used to. I have my kids, 3 kids. We are not used to having kids all the time. On our heads. So all those issues are creating a lot of social issues, including the mental problems. And I think Marco had alluded to that when he mentioned we cannot come up with one simple solution of staying home till the time everything is over. It is not possible. Similarly, I think there needs to be, online coaching for those. And I know there are a couple of resources which can help people gain their, to make sure they don't go insane. There are a number of things, fortunately, we have abused social media a lot, and that's true. There is a lot of crap there, but there are wonderful resources as well. You doing yoga, even online consultations which are available. So I think this is a very valid question, and it is, as you mentioned, the government cannot wash their hands away and say, it is public sector now, health is in private sector domain. The governments have a lot of responsibility, and mental health is one of the areas where they can really support communities.
We have a message from Raymond saying, well done, I'm enjoying the discussion. And we have also a message from, as actually comments from Mansour Salik. He's talking about, which is really very good questions. Said there is anti-vaccine movement, which is well known, and some people in the literature, they call it vaccine hesitant, There is anti-now mask movement, and these tend to be organized, either sort of rebellions movement or indeed right-wing or left-wing extreme type of groups tend to engage in these things. And the question is, how do we actually control that and prevent it from dominating the scene? Marco?
Well, I think I mentioned before, now the Colossus, Facebook and Google has started doing something to control the spread of misinformation in relation to anti-vaccine movement and in conspiracy theories and something like this in a semi-automated way. So there are ways that, let's say, artificial intelligence could help a bit detect keywords in the text and block some messages. There are limitations in that as well, but that might be a way forward. But at the same time, it has to come to the individual responsibility. And this is a problem related to media literacy and understanding what the sources of information really are and where this information comes from. And this is something not easy, and it is very hard to teach, and it requires, experience. Even scholars, even scholars in media communication have difficulty sometimes in detecting this. Now, because these are, the problem is that, let's say, 10 years ago, 20 years ago, when social media were not that prevalent, these movements were still present, and the conspiracy theories have always been there, But now with the social media, they have a major possibility to reach out to many or to millions of people. So we need to find the ways to block this. And this is a responsibility of health communication scholars as well, to try to find the ways to counter that argument. Now, there are not many places where we can do argumentation, we can debate. And it's usually when we live in our echo chamber, so we go on our Facebook, we see what we like to see. So we will never see an alternative view of reality. And this is a major problem of social media. So we need to look at information outside our bubble. And again, this requires a lot of effort from individuals, and not many people have it. Yes. But, assuming the point of view of a public health professional now and say, okay, then we need to put more effort to reach out to those who are against us, in a sense, to try to convince them. It's not about persuasion here. Again, it's about convincing. And you win an argument by convincing a person. And this requires debate. It's not persuasion, it's convincing.
Marco, do you have evidence? Because we've seen in some communities, and there is actually comments from Professor Ali Abu Thain, professor of primary care, saying that people are people anywhere, and resistance are there, and behavior difficult to change. But the only way forward is by law enforcement. I mean, it seems convincing people didn't work in many countries, including Iraq.
It's one way. I'm saying, again, when I talk about multiple types of intervention, law is one of them. It's not necessarily the only one. It might convince those who cannot be convinced. You know what I mean? Sorry. It might persuade those who are not convinced. The convincing can look for another segment of the population who are ready to be, in a sense, convinced, who are open to. So those who are undecided, those who don't know, or those who do not understand the differences between wearing a mask or not wearing a mask. So again, we talk about this a concept of segmentation when we talk about deciding the messages. What is the target group? How do we market the behaviors here? This is a social marketing terminology, and I bring it here.
Yeah.
So when we talk about this, so we need to really think about, we have an array of possibilities. It's not only one. It's not a silver bullet that we shoot and we read the majority on all the people. We have other ways. We can use disincentives, monetary disincentives, or different kinds of incentives, or we can use, so the carrot and the stick, in a sense. We can use so law and banning people, or fines, or we can give positive enforcements. So on the opposite spectrum, or we can use communication to remind people. We can use nudging, for example, so changing the environment, in a sense, changing what they call the choice architecture. We make the system ready for accepting people to wear masks and so on. We create, in every space, the social distancing part. Actually, sorry, physical distancing. I don't like the word social distancing. It has mental health implications. You're isolated socially. So we have an array of things. So we, as a communication specialists, communication scholars, communication managers, we need to consider more options, and we need to have engage with discussion with different people, different disciplines. Public health, and this pandemic has taught us, at least the realization I have made, that public health has become a relevant discipline. So it's not only the COVID-19, it's not only about communicable diseases now, it's about the consequence of COVID-19. You have mental health problems, you have chronic conditions that are going to appear soon because people do not go to the hospital anymore for curing their chronic conditions. And this will have a massive impact on the economy as well. The healthcare costs will grow up.
Yes.
So public health is a relevant discipline now, and we public health professionals, we really need to speak up more.
But that require, I mean, you raised the point, we'll come to it, require huge transformation in public health. We'll come to it. I want to go back to Lujain. Lujain, you raised one important question about the people in lockdown. I mean, those who are actually living almost hands to mouth, i.e. winning their bread on daily basis, they couldn't last long. Not like Europe, for example. In Europe, people lasted for 3 months lockdown. They respected that. So what's the solution for those people, in your opinion?
Actually, when the pandemic started, these people, they had support from the government, and for example, food supplies, what family needs for maintaining their day. Later, with the financial crisis in our government, in our country, as you know, these supplies or support by the government decreased. Although too many, let's say, people, Iraqi people, or let's say organization, non-governmental organization, religious organization, they try to fulfill this gap, by supplying these families with the daily requirement. But still, it's a life. It doesn't depend on food only. They need other supplies. So really, in my opinion, the let's say the lockdown should be minimized. Let's say for a week. When it's tend to be more than that, it will be difficult for these families. But nowadays we overcome this lockdown. The committee of the health and safety committee, they allow people to to go to their work and to go to normal, socialize with the COVID-19, and this is really a problem. Also, we have this, the gathering, like for religious ceremonies and the religious conditions that occur in our country. Every time we'll go, the confirmed cases will raise up, the number of confirmed cases. Although there is restriction, by the local government of the religious cities, by the central government, by the Committee of Health and Safety, yet there is no, you cannot control people for these events, in my opinion, and all my friends and colleagues, they call me, you are stiff and go by law. I think implementation or enforcing the legislations and laws is the only thing. Of course, in addition to, let's say, support of the government to the families in order to overcome this problem. And I think even in China, it would never, they would never come to success unless they implement laws, law and legislation. Everyone had, he should be quarantined, he should be moved to isolation, and so on. So conducting or performing laws and make it into executive laws, it should be applied. Otherwise, we cannot manage it. We cannot.
Yeah, thank you.
Keep this way.
Yeah, I was interested with your terminology, socialize with COVID. Tomorrow I'll have 19.
Right, yeah, that's right. That's right. This is what happened. Really, this is what happened here. So people, there is no really, you can go use the personal equipment measures. Well, I have a journey, from my work to the college, and I live in Al-Karh, and I work in ArPHA, so it's a distance, you know. Through all the journey to the work, I've never seen anyone who follow the personal protective measures. Perhaps, let's say 0.5% of those who I met them through my way to college, you know. Yeah. So how can we? From curve to RSAFA, you know. So I don't know, unless you prove it. Yeah. Unless there is law and there is a good implementation of these laws, I think even we may need the military to implement these laws.
Don't ask for it. Don't ask for it.
Yes, do you socialize with COVID?
I think that's this view from Iraq is interesting, and as I said, this crisis has opened us to different insights. An interesting insight and a new discipline that I have got exposure to during this crisis is the behavioral economics. And Doctor, you may try to use some of these measures, maybe starting with your own university, and see whether they are effective or not. Because they believe humans are not always behaving in a rational way. Humans make irrational decisions. And we cannot change human behavior. We can only change the context in which the behavior happens. So it could be, one way of looking at it and doing a small experiment to really understand what's going on. But Dr. Salman, to your point about community engagement, I would just like to mention that whatever you call it, I said I'm a student of communication. I don't go for the definitions, and frankly, I can't remember them as well. So it's my, anything that helps you take a pulse of the community. You understand their situation, and you are able to see their reality from their perspective, not from my perspective sitting here, in Lusaka, you from London, or something. And then are able to discuss with them and come up with solution that they think will solve their problem, is feasible, and they will be able to do that. For me, that is community engagement. Now we can call it community sensitization, we can call it community, tracking, we can call it anything. That is the key. Our topic today is on behavioral change. Believe you me, I never go for behavior change definition. No, I only understand it from the perspective of what the key benefits of that, or the key discipline of that would be.
Yeah, I mean, it will take us from our main topic, but I didn't want to indulge in it. But generally speaking, to be very honest with you, what you talked about, taking the pulse of the community, is about well-defined process of assessing need and listening to their opinion. That is not engagement.
And bringing in a solution.
Yeah, some process of engagement.
Co-designing is different.
Is actually when they are part of the decision process. That is what is it about. And that need to be absorbed in our region in different way, because tend to be executive powered without the worker engagement, executive power without the customer engagement, the blah, blah, blah. I don't want to go through it. And let me refocus our attention. I'm intrigued by the idea that community behavior don't change. But if we look across history, and I alluded to the one or two books by Hayes and others about the history of epidemics and pandemics, people change. Following every epidemic, people change. Because the science change. I mean, Marco quite rightly said, until today, we don't understand the virus fully. There are a lot of missing jigsaws here. And the risk of the infection may be more dangerous than we expected, because some of the studies now showing that even those called recover, i.e. discharge from care, hospital or otherwise, still continue after 6 months to have some symptoms and some problems. in their daily living. All right. So it's a dangerous virus. It's a dangerous situation. We are going through it. 4 countries now in our region, UAE, Iraq, Tunisia, and Morocco, we have seen worrying increase over the last week or two, you know, and we believe it's going to go up, you know. Luckily, the number of deaths is relatively low. I mean, this is very lucky for the region. Although we are now in much better position than February in managing these cases. We don't have a new treatment, we don't have vaccine, but whatever available to us now is almost worldwide. We converge about some protocols, guidelines for a treatment, which most of us are following it, which is actually very good. But I want to, the last few minutes, use it in a way, looking at the way forward, because this virus most probably will be with us for years to come. Most probably will be like another flu, but not necessarily the same severity. It will continue to be severe and problematic, you know? So what is the way forward? Lujain, do you give me 2 points, please? We have 4 minutes.
For me, first, we should
I hope
implement.
electricity is not disconnected.
Yeah, it's okay. It's okay. I have UPS for the for the internet. It happens in the best countries, huh?
Yeah. Mind you, in Los Angeles, they cut.
Not only in Iraq.
They cut the electricity 1 hour every day. Don't worry, it's happening everywhere.
So this is the 1 hour in Iraq. Anyway, for me to implement the law, but also the families and should be supported. Those for let's say low-level income, or those who live by day for their work, they should be supported by the government, you know, and to minimize the period of lockdown if needed. To have the period lockdown. Of course, people should have personal protective equipment, and they should be, laws of the health and safety committee should be implemented with the support of the government to the families.
Marco? Thank you.
I think an important thing we need to consider now for the future is how the vaccines will be made available to everyone, and this has implication for behavior change. So we have to tell people that you're gonna do, you're gonna take a vaccine. You should take your vaccine. We need to make sure before that everybody has access to that vaccine. So we need to have plans for global coverage of vaccines, and this of course requires planning in advance. There was an interesting paper by Jeff French, Doug Evans, and Samir Deshpande. I can link it to the chat if people wanted to. Who require, it's time to start thinking about that now, in relation also to the fact that there are anti-vaccine movement still present, and they will start firing up their weapons very soon. So we need to make sure that.
Marco, we have a vaccine for polio since the 50s.
Yeah.
We couldn't eradicate it.
Yeah.
A few days ago, the last week, we have a surge in number of polio cases in Sudan and other countries in the region. So vaccine is not the panacea, as some people.
No, of course not.
Be very careful about selling. You are the master of communication.
But here I put the point. The point I make.
Control.
The point I want to make is about an equitable access to vaccine that will help promoting the behavior. So if I can tell people, now you need to take the vaccine, and they go to the hospital and say, no, the vaccine is not available, then it's a major mistake.
Marco, thank you very much. We reached the end, and I would like most sincerely to thank you for your support to the Arab Public Health Association and participation with us.
You're welcome.
I really enjoyed every minute, and I do apologize for the many people which I really could not read their questions because of the time factor. Lujain, Dr. Lujain, thank you very much indeed. It's always a pleasure to see you.
Thank you.
Dr. Marco, it's a pleasure to see you again. And we are very sorry for what happened to the beautiful Beirut. And I know with your determination, you are going to rebuild that beautiful city.
Inshallah.
Yeah, and Fayaz, pleasure, sir, meeting you. And I hope we'll see you in person. And I'm most grateful for the recommendation from my dearest brother, Dr. Wasik Khan. Thank you very much indeed all. And next week, our session will be on COVID and reproductive and sexual health. Good night, everyone. Good night.
Thank you.
Bye-bye.
Bye-bye.